Yes. We have a thumbs up. So so I'm just going to very briefly introduce Peter Najjar, who is probably one of the very first people that I met when I came to Johns Hopkins. I don't remember how the Armstrong, maybe it was through you.
Possible.
Yeah, through you, Craig.
Yeah.
But this early sort of discussion of where was autonomy going to be deployed, and where did you really find the safety critical applications, involved, of course, transportation. It involved a number of fields, but I think in particular medicine, of course, is the area where there's the greatest attention to, if you will, making sure that these are really engineered systems and we get them right. And of course, the Armstrong Institute is actually really focused on ensuring these types of outcomes for surgeries. And so I found Peter to be very insightful and very thoughtful in terms of looking at the broader technical landscape. And I actually am embarrassed to say that I only just figured out that you have an M.B.A. And
Good,
so
I'll take that as a compliment.
Yeah, well, I don't have one, but I have a brother who went to the same school you did. And so I've often wondered at the fact that you do tend to take a very big picture look at this. And a lot of times we'll talk about the business aspects of it as well. And I wondered, is that a School of Medicine thing, or is that a Peter thing? And now sort of reading your background, I realized that, yeah, it's probably a Peter thing. So I've greatly enjoyed our conversations over the years and look forward to your talk. So thank you, Peter. Yep.
Thank you. Yeah, no, I always learn a lot, and I think just interacting with IAA, I mean, it's been super a very, very rich set of interactions. I think for me personally, and for our group as we think about deploying this stuff, in the real world. So I'm very, very grateful for that. And thanks for inviting me. So we have like a little less than an hour, is that right? And the goal is, I think, for this to be as interactive as possible, so that I'm just not just kind of talking at you, hopefully. Reasonably interactive. Reasonably interactive. Yeah. Okay. So yeah, just please interrupt at any point.
So those of you online can kind of raise your hand, I guess, and we'll
perfect. And should I be monitoring for?
No, we'll if we see someone raising their hand, we'll let you know.
Perfect. Okay. Sorry, I'm just literally I'm actually on call, and I'm just somebody's I have to head back to the hospital after this time. Okay, so great. So learning objectives, we'll just talk about secular trends that drive gaps in quality and safety. And then we'll talk about how we're doing sort of data integration and organizational redesign to be able to deploy some of this new technology that's just exploded in the last couple of years. A couple of my disclosures not particularly relevant. But I think kind of in the vein of disclosures, I'll make some confessions that I think are relevant. One is that I don't have any technical training. So I've listened into some of these seminars, and I barely made it through freshman calculus. And so I'm self-taught, like a tiny little bit of linear algebra, and trying to learn enough of the technical underpinnings of this kind of technology and model training and all the various approaches, specifically to be an effective practical user and deployer of the technology. So I admit a very severe limitation there. But I've been tutored well, I think, by a lot of folks, including many in the room. I'm a surgeon, so a lot of my kind of clinical lens will be through the work that I do in the operating room in the clinic. I'm a colorectal surgeon. I take care of a lot of cancer patients, IBD. And the third is I'll admit to sort of a bias around being excited about the technology. I was just talking with Tony about this new report that came out from, I think, Menlo Ventures, and they were talking about sort of the uptake of generative AI in American enterprises. And historically, healthcare has been sort of a technology laggard. We're very, very slow to deploy technology. We were one of the only industries where the government literally had to pass legislation to force us to use computers, which is, meaningfully used. I mean, it's really kind of comical, but striking and true. I mean, you had to, pry the paper charts out of our, cold dead fingers basically to get us to switch over to computers. And I think anecdotally, what I've seen to be the case is that that's because legacy sort of deterministic rules-based algorithms just weren't able to sufficiently deal with the enormous variability that exists in healthcare applications. And so I think that we were kind of underserved by what I'll call legacy technology or pre-generative, AI technology. And I think that what you're seeing now, where it's this bizarre complete 180, where healthcare by almost every metric is one of the leading adopters of generative AI. We're spending more than any other industry on it. Our contracting times, which have been notoriously long, are compressed. And so we're acquiring and deploying the technology more quickly. And the vast majority of the spending is actually going to startups and not legacy technology vendors. And so I think that's really compelling evidence that there's just been a lot of pent-up demand in healthcare that just we haven't been able to meet. And this kind of new era of generative AI is really kind of starting to meet that pent-up demand. So I'm excited. There are a lot of limitations, and we'll talk a little bit, through them. But my bias is that this is going to be quite transformative for healthcare delivery, generally speaking. And I think the next 5 or 10 years are going to be really remarkable. Great. So those are my confessions. Agenda. So we'll talk a little bit about the promise of technology and quality and safety. We'll talk a little bit about, my simplistic understanding of sort of data fusion as a key animator of that promise, and then get sort of into the practical implications of these kinds of technologies for clinical operations. So first, the promise, and I'll zoom out a little bit and talk a little bit about where we're at in terms of kind of our ability to deliver care. And so the first is this kind of observation that quality and safety. So quality and safety operations is paradoxically hard. And what do I mean by paradoxically hard? I'll give some examples sort of from clinical practice. So our ability to sort of treat and cure disease is expanding exponentially. And we're really able to do some remarkable things that are happening, I think, sooner than many of us even thought possible. So a couple of examples from my field. So we've been doing oncology trials for decades now, and there was actually the first solid organ cancer trial that had a 100% remission rate ever in the history of oncology trials, was published back in 2022. It was out of MSK, although the kind of precursor work was done here in terms of using immunotherapy to treat a specific genetic variant of colorectal cancers. And granted, it was a small trial, less than 20 participants, but they set it up such that we would identify the folks who had this particular genetic variant in their tumor. It's a small percentage, depending on the series that you look at, it's probably around 5%. So unfortunately, not all rectal cancer patients were eligible. But in that subset, the trial was designed to first give neoadjuvant immunotherapy and then switch to traditional neoadjuvant chemotherapy and radiation therapy, after the administration of immunotherapy, and kind of see if the immunotherapy made a difference. And in 100% of the trial participants, the tumor melted away completely, and none of the trial participants proceeded on to standard of care because the immunotherapy was so profoundly effective. I mean, it's like just absolutely remarkable. And we're talking about, immunotherapies and molecular genetics or, in cancer are going to render surgical oncologists like me obsolete. And we thought, we still have a little bit, more runway than this, but really kind of remarkable and wonderful for patients. And then if we zoom out, kind of looking at all comers, in addition to these like big picture breakthroughs, you have the 1,000 sort of myriad small improvements in every aspect of what we do. You got it. So we have these kind of 1,000, myriad improvements, and so you see that kind of across the board. So when we zoom out, we look at colorectal cancer mortality across the board, and we plot the Kaplan-Meier survival curves. by era. And, historically, we talk about an era like, the 80s, the 90s, but these eras are 2 to 3 years long. And you see that the Kaplan-Meier curves actually significantly deviate in the right way. And so what that means is that you're more likely to achieve long-term survival if you were diagnosed with a colorectal cancer in 2018 than if you were diagnosed with a colorectal cancer in 2015. And that's really remarkable. I mean, that is a remarkable rate of progress. And I think that it's important to sort of, be excited about this kind of stuff. And when you look at sort of population level analysis, lest we think that this is sort of a selection bias and that we're just kind of operating on healthier patients, it's actually generally the opposite is true. Patients are older, sicker, more comorbidities, more medications. And so when you look at overall colorectal cancer mortality, that also continues to decline in almost every population except for the young. For some reason, we think it's likely environmental factors. We're seeing an uptick in colorectal cancers in the young that we historically haven't seen. But that's probably an environmental factor that's kind of causing new cancers. So you look upstream even from treatment into screening, colonoscopies, et cetera, and it's clear that not only are we treating these cancers more effectively, we're also probably preventing their recurrence. And so we have these incredible advancements, and yet we see this sort of paradoxical challenge where our ability to actually deliver sort of the state of the art is continually challenged. So Cliff Coe is a well-known colorectal surgeon, actually, who's been doing quality for decades now at the American College of Surgeons. And he says that suboptimal care is a much less tractable problem than perhaps was anticipated at the dawn of the quality and safety movement. It's now clear that QI itself requires improvement. And you see this in these kind of persistent gaps. This is a surgical complication of colorectal cancer surgery, postoperative compartment syndrome, and it seems to be increasing. It's preventable. It's likely due to prolonged operations and steep lithotomy where you're kind of almost hanging on your head because of the advent of robotic surgery. When we zoom out, we look more broadly. This is a great paper by a group out of Boston from a couple of years ago. And they sort of manually reviewed a couple thousand hospital admissions, and they found a persistently elevated adverse event rate of 7%, and about 1% of those adverse events were serious. And these were all kind of preventable medical errors. And so, how do we explain this, right? Where we're kind of able to do all this remarkable stuff, on the right side of the screen, and we still have these persistent gaps on the left. And I think the way that I conceptualize it is that the sort of medical science is increasing exponentially, and we are only improving in terms of our operational delivery linearly. And so even though we're getting better in absolute terms, the gap between what we are able to do and what we actually do is widening. And that's the way that I kind of reconcile these two kind of secular trends. And so I think that, in order to understand what impact AI and kind of assurance technologies can have on this, we've got to dive a little bit deeper into understanding why this is the case. What are the secular trends that are kind of driving this gap? And these are kind of my musings, backed by a little bit of evidence here, but I think these are the three main kind of drivers of this persistent and increasing gap between what we are able to do and what we actually do for our patients in a scalable, kind of replicable way. So the first is a perpetual increase in clinical complexity. This is a quote out of from a paper that actually a friend of mine, Ziad Obermeyer, wrote almost a decade ago now. And he wrote that the complexity of medicine now exceeds the capacity of the human mind. Computers are the solution, but using them to manage this complexity will require fundamental changes in the way we think about thinking and in the structure of medical education and research. It's like quite a prescient statement, a decade ago. And then if you look over here on the right, this is a chart that looks at new controlled trials published annually. And this ends in 2010, but it's asymptotic and it's increasing, at an ever accelerating pace. And it's just impossible to keep up. We've done things in the field, like you see increases in subspecialization, for example, like 20 years ago, so colorectal surgery as a specialty was kind of like, what do you need to go do an additional year of training to learn how to take a colon out for? That's just a core part of general surgery. I know with my trainees today, I don't worry about their ability to do 1990s colorectal surgery, through a big incision and kind of taking a colon out. To practice colorectal surgery today, you need to be able to do open surgery, laparoscopic surgery, robotic surgery. You need to be familiar with advanced endoscopic techniques, advanced imaging techniques. You need to know what laser confocal endomicroscopy is. You need to know about molecular genetics and whether or not your patient is eligible for neoadjuvant immunotherapy that didn't exist, 15 years ago. And so the complexity is just exploding. And we've tried to keep up with subspecialization and increasing kind of our workforce, but it's just impossible. There's no way to keep up with that pace of expansion of knowledge. And our patients are also getting sicker, older, and the technologies that we use are getting more and more complex. I've got like a $3 million robot in my room, that people have to learn how to use. And it's just a massive challenge to keep up, and we're clearly failing. The second is consolidation and network growth.
You say you're clearly failing. The numbers actually don't show that, right? The numbers show you're succeeding.
Well, I would argue that maybe my bar is a little bit higher. So I think that if we fail to deliver optimal care, is the way that I would describe it. So we are, I'll say it again, we're getting better in absolute terms. So I'll give us that credit. But if you're a patient and I tell you, we could have gotten you through this, the science exists, right? But we didn't. Why? Well, we just screwed up. I hadn't read that paper, or that's a really tough thing to tell to the public and to your patients, right? Folks expect us to be able to deliver the state of the art, especially at a place like Hopkins, right? So it's a great point. But
my mother just the other day was talking about a neighbor whose marriage didn't work out, and he's a cardiologist. She said all he does is come home and read papers.
Yeah, and he still can't keep up.
And that's a criticism.
Yeah.
Well, it's true in engineering too, although maybe the consequences of missing something aren't quite so severe.
Yeah. So all great points. So then there's this issue of consolidation network growth. This is a chart from the Kaiser Family Foundation, looks at the number of hospitals that are part of hospital systems in blue and freestanding hospitals, independent hospitals in yellow. And you'll see that the consolidation is just ever increasing. And if you play this graph forward to present day, it's still continuing up and to the right. And you'll see that the slopes, the astute observer will know that the slopes of these two curves are not absolutely equal. And that's because it's not just that independent hospitals are being absorbed into health systems, but they're actually also failing and closing down critical access hospitals. So we're losing independent hospitals, and more people are being pushed into sort of hospital system. And there's, theses can be written about why that's the case. There's a whole bunch of legislative reasons and economic reasons, et cetera, that this is happening. The sort of, private practice surgeon has disappeared. We're almost all employed, nowadays by large health systems. What that means is that the old way of kind of managing quality, where you would walk around the ICU, walk around the operating room and say, I don't like the way that you're doing that, turn your body to the left, or remember to do this. It doesn't work in a large integrated system. How can I assure myself that the quality of colorectal surgery that's going on down in Florida or in DC is kind of where we want it to be. And so we haven't really evolved the organizational tools to be able to exert operational control and to develop sort of operational insights around what exactly is happening in these large diffuse networks. And that sort of organizational engineering is still in its infancy. And so again, we're seeing this kind of gap that's being exacerbated by this level of consolidation. The promise was that we'd have these big integrated systems and we'd be able to take advantage of economies of scale. And we haven't seen that happen. For the most part, we've just extracted higher pricing from commercial insurers and not necessarily meaningfully moved the needle on quality and safety performance. And then the third, and this is a really, really big one, is staffing and productivity trends. And this shows no sign of abating. We've got a global workforce shortage, and it's particularly acute in healthcare. So all of the sort of secular trends and demographic trends, et cetera, are very, very real. average tenures are dropping, so that institutional memory that you'd have from a nurse with 20 years of experience is kind of evaporating. It just doesn't exist anymore. And you see sort of the value of that tenure in this paper down in the lower right that looked at the length of stay and likelihood of readmission as adjudicated by the years of experience of the nurse who discharged you. And you find that nurses who are more experienced are able to get patients out of the hospital sooner, and those patients are less likely to come back.
Wow.
Presumably through a whole host of different sort of interventions, better patient education. They've been around the block before. They know that they'll give you the tips and tricks of make sure you stop by the pharmacy on your way home to pick up this, that, or the other. And so that kind of institutional knowledge is not really formally encoded in any of our policies, right? And it really shows it's hugely impactful. And this is going away. We just do not have that nursing tenure, anymore. And that's across a whole host of different professions. This is kind of just one example. And then you see that in this other really striking graph up at the top here, which is a measure of labor productivity. And you can argue about how to measure that, but functionally speaking, sort of like how many units of output do we get for every unit of labor input, right? And in almost every industry, we see positive labor productivity curves, right? You can manufacture more flat screen TVs per hour of human labor today than you could 15 years ago. You can staff a larger hotel today with a smaller workforce than you could 20 years ago. But healthcare is the outlier. We've actually seen negative labor productivity growth, which is really striking. Which means that core sort of promise of technology, right? The core underlying promise of technology is you can do more with less, right? And it doesn't seem to be true in healthcare. And I can see that anecdotally. I can't do more colon surgeries a day today than I could in the 90s. In fact, it requires more time and more humans in the room, to manage the robot, for example, which extends case times and requires more staffing. And so this kind of labor productivity challenge, coupled with our shortages, coupled with this increase in complexity and sort of the inability of kind of human cognition to keep up, and this consolidation network growth where we don't necessarily have kind of the organizational paradigms yet to be able to assure quality and safety, all kind of coalesce to create this kind of perfect storm here that we're trying to battle. And so thinking through this, like, okay, well, what would the ideal state be? How do we solve this this challenge or this set of challenges? And I think it's like useful to, if you'll permit me a little bit of like a flight of fancy to think about like, what's the pie in the sky kind of future look like? And then how do we work backwards from there in a practical way to figure out what we're supposed to be doing next Tuesday, to sort of realize that benefit. And so, in my sort of unsophisticated understanding of what the promise of AI is, I think it probably is, something like this. So I'm really hoping, I give this talk to a lot of different audiences, and the hit rate for people who recognize this character is very, very low. Do people know who this character is? Yes?
Yeah, online, you should give a thumbs up if you recognize this guy.
I was really hoping that in this group that, I wouldn't kind of be the outlier, but maybe.
Oh, there you go, you got
Good.
a few,
Okay.
yeah.
So this is the Doctor from Star Trek Voyager, all right? And it's a next generation spin-off. It was a TV show in the 90s. And the plot line is that this the Voyager spacecraft in the 24th century, I think it was, gets sucked through a wormhole and deposited in some distant quadrant of the galaxy, and is kind of slowly making their way home. Even at warp 9, it's going to take however many decades to kind of get home. And every third or fourth episode, the crew runs into some sort of kind of medical emergency. Some sort of alien virus infects the crew, or there's some sort of traumatic event. And there's no human doctor on board. And so when this, whatever the kind of medical affliction, occurs, they summon this emergency medical hologram, known as the Doctor, played by this character. And he kind of materializes, and is familiar with the entirety of sort of human and alien medical literature, So knows all the latest papers that got published, keeps up with that graph, which I think, in 24, 23 or whatever, that graph is probably even steeper, right? And then orders the appropriate sort of diagnostic tests and interprets everything, interprets the tricorder data, et cetera, and then says, here's what I think is going on, and here's this kind of suggested, course of treatment, and works with the crew to, sort of, administer that treatment and monitor the patients and make sure that everybody's getting better. And I think it's a couple of things are interesting. I mean, even in this kind of, idealized future state, this emergency medical hologram is still sort of an assistant to the crew, right? So it's still sort of, there's still a human in the loop, right? And relies on kind of the humans to make the final decisions. And I think a little bit, I think these are prescient writers, but this guy is played as kind of an aloof and somewhat annoying character. And I think that, that sort of like know-it-all kind of, I've got all the answers, type of approach to technology development that we've seen historically, in healthcare. I think that kind of comes through in this character, which I think is a little bit funny. So, all right, we've got this kind of idealized future state, at least my version of an idealized future state, take it or leave it. How do we kind of work backwards from this into kind of practically understanding how we get there? And I will say, I will confess to, over the last 3 to 5 years, thinking that this really is kind of a distant fantasy, right? To, yeah, sure, maybe like the hologram technology where this guy can actually pick things up and manipulate the physical universe, but we're seeing humanoid robots now, and we're seeing, this explosion of generative AI. And I mean, I think it's quite clear that this is not going to take us 350 years to get to something that very closely approximates the kind of fantastical, imagination of the doctor on Voyager. And that's very exciting. And so I think it's a worthwhile effort to think about what are the sort of predicate structural foundations that we need to have in place in order to be ready for this technology, as it advances and evolves. And so that's where I'll step back and kind of distill down what the tasks at hand are, so we can think about like where this technology needs to be developed and applied. And if I boil, down what we do in healthcare to its kind of simplest essence, the simplest that I can get it in my own mind is that when we care for patients, what we do is we predict and modify their future health states efficiently. Somebody comes and sees me with a cancer, and if I'm doing my job well, I'm predicting what their future health state would be via the natural course of the disease left untreated. And then I have treatment modalities that are able to modify that future health state prediction to a more favorable one. And ideally, I'm able to do that kind of safely and efficiently, right, in a cost-effective way that's scalable. And if we think about improving care, right, well, what does that mean? It means decreasing the risk of inaccurate predictions, or what I'll call kind of actuarial risk. And that's probably, most akin to sort of diagnostic error, right, where we're kind of wrong about what's going to happen here, what the diagnosis is. Or an ability to efficiently modify, and I'll call that operational risk. And that's either just that it's too expensive, or it's not available, or that we make errors in treatment. We make the right diagnosis, but we prescribe the wrong dose or the wrong antibiotic or what have you. And so we're unable to efficiently kind of modify the future. So if we're going to measure and modify the actuarial and operational risk, then I think that we've got to do these 3 things. We've got to exponentially expand data collection. And I think that we have to do that both in terms of scale and scope. And I think about this in a really simplistic way. When you look at sort of commercial insurers, they're actually able to predict actuarial spend very, very accurately over 5 years and 10, 15 million covered lives. And so as we kind of make the cohort size smaller, and we shrink the temporal horizon over which we're trying to make these predictions, the amount of data that we need stays roughly static. And so we need an increasing amount of data per unit time and per cohort of patients. So when we get down to trying to predict what's going to happen to 1,000 patients in a hospital over the course of the next 2 days, right, we just need a lot more data about each individual patient and over each individual kind of unit of time. And we're going to do that by expanding the amount of data that we capture with sort of the alphanumeric baseline, the EHR data that we've got. We've also got to move into non-alphanumeric data, right? When we treat patients, we do a physical exam, we have sound, we have sight. And so far, for the most part, although this is changing rapidly, most of the technology that we deploy is strictly limited to kind of alphanumeric, training and detection. And there's this neat kind of anecdote by Jan LeCun, who used to run AI science at Meta, and I think now he's been replaced by like a 25-year-old or something like that. But and he kind of said, well, if you think about a human child, by age 4 or 5, the amount of visual data that they've incorporated into, their training or pre-training, I guess more appropriately you call it. It's like 20 megabits a second for both eyes, over 4 years, it's about a petabyte of data. And that's about 100 times larger than the largest corpus of alphanumeric data that we use to train kind of frontier LLM models. And so, it just speaks to the kind of scope issue of where we need to move into real world data collection, waveforms, vision, audio, and eventually even tactile information, surgical kinematics, those sorts of things. And then if we're able to expand that data collection, we should be able to do better prediction, and we should be able to transition from retrospective, sort of this is what happened last quarter to the patients, to real time, this is what's happening right now, to predictive, this is what's going to happen in the next hour, tomorrow, next week, next year. And then eventually to prescriptive analysis to say, this is what you should do in order to alter what's going to happen tomorrow to more favorable scenario. And then when we get there, when we have that prescriptive data analysis, again, because of all those limitations that I just talked about on the previous slide, then we need to take that, we need to automate operations at scale where possible. So where we know with a high degree of certainty kind of what the right thing to do is, then we slowly sort of automate our systems to ensure that that right thing gets done. And you see examples of this where we can do this with like legacy technologies, things like checklists and, automated, sepsis alerts and these sorts of things. But I think our ability to do this is going to exponentially increase with the use of these new kind of generative AI technologies. And that's like a really, really simplistic sort of rundown of what we probably need to be able to do in order to materially move the needle on healthcare. Yeah.
Question there. A lot of what you're talking about could be at sort of the generic procedural level as compared to the patient-specific level.
Yeah.
I mean, this is sort of this whole two loops thing I always talk about. How do you see that proceeding? In other words, if you want to get infections down, or you change the procedure, and if you've had one, you have a witch hunt to try to figure out how it happened, so you can prevent it. As compared to, I have this particular patient, and I have several surgical approaches I could take, but this is the one that I should take for this person.
And so your question is?
Well, both are important, but how do they interact? What's the proportion that you see?
No, that's I see what you're saying. So it's a really good question. So I think that, maybe restating your point a little differently, it's kind of like, what is our generalizable understanding of kind of best practice? That's one bucket of knowledge and predictive ability that we need to enhance. And then 2 is kind of the personalized medicine kind of approach, right? So for this unique set of physiologic, factors in an individual patient, how do we map kind of the generalizable knowledge that we've got onto, the specific. Yeah. And I do think that we need to do both. And I think that the solution to both, it lies in this kind of,
okay. I'm sorry, I shouldn't have hijacked you so soon.
No, it's a really great point. So like, in order to be able to, for example, uncover novel process outcome relationships, let's zoom in.
You have to know what the process was.
You have to know what the process is. Right now in the operating room, we don't know what the process was. We have like a dictated op node, which is even worse than it used to be, because it used to be that you pick up the phone.
Much more eloquently a talk I've given about 100 times. This is great.
Yeah, and now it's like a templated op report. It tells you virtually nothing about what actually happened, right? It's generated for billing purposes, really, if I'm being honest, right? And then we don't know. We don't have the data to be able to say, if you use this type of suture, you're more or less likely to develop an infection because we don't even have the underlying data really.
Yeah.
And so that's kind of step one, to develop that generalizable, kind of knowledge base to be able to more accurately predict with evidence, right? What the sort of appropriate sequence of events in a given care process should be. And then the secondary question is really just having data that are scaled enough such that you can do the subgroup analyses that you need to do. Such that you can say, okay, now I just want to look at patients between 55 and 57 years old with these 3 comorbidities that have a systolic blood pressure of this. And I want to understand kind of what suture to use in that particular case. So I think that you're spot on, and I think that there's kind of an interplay. We probably need to start with the generalizable knowledge, and then move on to kind of the deeper patient-specific predictive knowledge. And different fields of medicine are at different kind of places in that kind of evolution. Like we're doing a lot of personalized care with medical oncology, for example, where we can do kind of tumor sequencing, and it's a little bit easier to kind of capture the processes because it's like, which chemo drug did you administer? Right. And that's a much easier sort of process variable to capture than, how exactly did you create that anastomosis, in the operating room, right? That's a much sort of, that's where you need the video, and and the alphanumeric data just aren't sufficient. And so it's kind of, the answer is a little bit different depending on the specific field.
I'm sorry, I want to hear the rest of this one.
Yeah, so I'll try to kind of speed through the rest. But this is this concept of kind of data fusion. And a couple of examples outside of healthcare that I kind of found striking, and I used to try to help folks in healthcare think through, how impactful this is. So this was a report that was released by the Director of National Intelligence a couple of years ago. And it was talking about sort of this availability of commercially available data. So these are kind of data sets that are sold, publicly, your sort of iPhone GPS information, the battery level that you had when you ordered the Uber, et cetera, et cetera, et cetera. And so this report states that today, in a way, far fewer Americans seem to understand, and even fewer can avoid. Commercially available information includes information on nearly everyone that is of a type and level of sensitivity that historically could have been obtained, if at all, only through targeted and predicated collection. And I think this is really striking because what this says in my terminology is that we're able to acquire these individual data sets, fuse them, and then develop insights about you that we historically would have had to hire a spy to follow you around for, and still might not have even been able to develop. So you think about taking that level of kind of data fusion and applying it to healthcare and to an individual patient, and your understanding of the patient's physiology, their values, kind of what their day-to-day life is like, how much do they walk, where do they travel, all these things that factor into sort of creating treatment plans is really, really critical. The second example I'll give is from this sort of so-called 5th generation fighter jet platforms, F-35. In my naivete, I would have thought that the reason that these jets achieve kind of complete aerial dominance is because of their kind of flight characteristics. They can fly faster, farther, take tighter turns, carry bigger bombs, and I thought that was kind of intuitively what the reason was for their aerial superiority. And it turns out that's not the case at all. And so in sort of previous generation jets, you have all these kind of sensors. And really the integration of the sensor data was the pilot's job. So you'd have a radar contact, an infrared signature, you'd have transponder data, you'd have ground control information, you have rules of engagement that varied by kind of your longitude and latitude. And the pilot would have to sit and kind of integrate, all of these data points when there was kind of a radar contact to say, okay, is that an enemy fighter or is it a bird, and where are we exactly, and what do I do about this? And what these systems are able to do now is fuse all of those data, do all that pre-processing, synthesize it, and present a single fused battlefield view of the pilot's visor and heads-up display. And so now all of that kind of data fusion and synthesis is done for the pilot. And so it's like, enemy MiG, at 2 kilometers in this direction, flying at this rate of speed, and here are the rules of engagement for this airspace. And now the pilot is freed up to actually devote their cognitive resources to tactical decision-making, right? How do we respond to this information, rather than having to spend the majority of their cognitive bandwidth on synthesizing the information to even understand what's happening. And that's exactly the type of thing that we need to do to our human clinicians, right? We need to offload them cognitively from all of the sort of synthesis work and really get them to be performing at the top of their license and making kind of tactical decisions and, making the decisions that we still can't kind of, outsource to an algorithm and that we can't and don't want to, for a whole variety of reasons, automate. And so, thinking about that and mapping that onto healthcare, this is kind of what it looks like today. And this is nothing to shake a stick at. When I was in training, I would walk around and have to copy down vital signs from, paper, slips of napkin, coffee stain napkins, and these kinds of things. And now we've kind of moved everything into the electronic health record in most American health systems. And then we can kind of do these post-hoc analytics and hopefully kind of lead to these improvements. And the future state is that we really kind of sensorize and capture more information about the medical encounter, and that's physiologic data, device data, audio, video, all the things that we've been talking about. We process it. We offload as much work as we can in terms of documentation, et cetera, in the EHR. And then we can do more robust kind of post-hoc analytics, uncover those novel process outcome, associations to say, here's the type of suture that you should be using because we know that it leads to a lower leak rate or complication rate or what have you. And then eventually to move to real time, right? To say, hey, this process is kind of going off the rails. If we allow it to continue, we're going to get to this unfavorable outcome. Let's prescriptively kind of intervene and suggest something. And we're seeing examples of this working really, really well. There was a great paper that looked at an algorithm that predicted intraoperative hypotension. And if you equipped an anesthesiologist with that algorithm, patients spent less time hypotensive with low blood pressure in the operating room, which is a huge predictor of perioperative cardiovascular events. And so this is kind of the future state that we're working towards. And it's happening in bits and pieces. A couple of obvious kind of examples that map onto this framework is, we have ambient scribes now. So instead of having to manually write your note, you sensorize the clinical encounter with a microphone, and then, the system transcribes, the discussion with the patient, and then, uses LLMs to generate a draft progress note for you. And so it's an example of the type of sort of things that we can offload using this kind of infrastructure. We're doing it with waveform, putting cameras into patient rooms, trauma bays, operating rooms, all in an effort to sort of sensorize and capture and do this sort of automation work, improve our predictability, and sort of offload and reduce the margin of error that exists in a lot of these kind of unmonitored, uncontrolled, poorly understood processes of care. And so, implications for our operations. I was really, really fascinated by this one anecdote that is outside of healthcare again, which is Chick-fil-A. And these guys, we all think, okay, Chick-fil-A is nice and they're polite and they say it's my pleasure and the chicken's really good. But they're like strikingly high performers. Their revenue per square foot, of store space is really, really high. Their net promoter score is really, really high. Their employee engagement and satisfaction scores are really, really high. They're just better across the board, right? And in terms of financial performance and everything else. And they're incredibly skilled at doing this kind of operational management. This example, like at peak hour at Chick-fil-A, apparently they serve a sandwich every 16 seconds, a box of nuggets every 25 seconds, a car through the drive-thru every 22 seconds. It's really, really compelling. I was fascinated to learn that they have this incredibly sophisticated IT infrastructure. They deploy bare metal Kubernetes servers and do all this incredible kind of architectural engineering in service of this level of operational performance. And a small example of this is, when you have a box of chicken nuggets that come out of the fryer, there's only a certain amount of time that you can leave them under the heat lamp before the food safety issues and they get dry and they're not as moist, et cetera, et cetera. And so they used to have just a manual little timer that, you'd pull the chicken nuggets out and then you'd clear the chicken nugget timer and restart it, and then it would start to count down from whatever 18 minutes or whatever the length of time was. And so they re-engineered this, and they basically used a computer vision system where the chicken nugget tray would have a barcode scanner, would have a barcode on it, and they put it into the warmer, and this system would read the barcode and say, okay, this is a fresh plate of, fresh tray of nuggets, and it would automatically kind of start the timer, and then it would be able to then monitor, were those chicken nuggets still there when the timer elapsed, or were they appropriately kind of removed and thrown away? and how many of them were left over, right? To understand like how much waste is there.
Wow.
And it's really, really sophisticated. And so this is a quote from Alain Nicolet, who's the enterprise architect at Chick-fil-A. And he was talking about this kind of smart restaurant work. And he said that a resulting principle is to make the right thing, the easy thing to do. The black box timer solution, the old one where you had to kind of push the timer manually, does not support this goal. It requires multiple taps by restaurant team members to start timers and an excruciating 3-second press and hold to cancel an existing timer. And it provides zero systemic access to data. And this is how I want our health IT folks to talk, right?
Yeah.
Like the level of empathy, for example, to describe a 3-second button press as excruciating, right? Means that he understands that it's 3 seconds, but these guys are trying to get a sandwich out every 16 seconds. So it's a meaningful percentage of time, right? When we say, well, it's too many clicks, right? So that level of empathy, right? Operational empathy with the front line is really compelling. And then the commitment to sort of having systematic access to the data so that you can continually model and improve the performance at each restaurant by creating operational systems that both increase efficiency and expose the processes for analysis and insight generation, improvement, et cetera, is really, really compelling. And I think is kind of serves as a model for like what we're supposed to be doing in healthcare. And so for us, the kind of Armstrong innovation strategy, and we're lucky, we have phenomenal health IT folks at Hopkins, and we have this incredible sort of community across the university, the Applied Physics Lab, School of Engineering, et cetera. And so we can, I think, do this stuff, quite effectively. But there's really kind of a 3-part test for new technology adoption, I think. And you really today have to get a perfect score. The first is that does it do something useful for us today? And I call that kind of the off ramp, right? Like, other industries, venture funded, where you can have like, you can take a lot of capital risk on, try something that has a 90% chance of failing, but if it works, it's going to be really worth a lot. Right? We can't do that in healthcare. We can't fund that type of innovation with operational dollars. Our margins are 2.5%. So, this stuff has to work on day one, has to provide meaningful benefit on day one. And I call that an off ramp because it's kind of like a value off ramp. Even if the technology doesn't mature to the state that you hope that it'll mature to, even if it just gets 1 or 2 clicks kind of along that road, you still derive some benefit from it, right? And those are the kinds of technologies that we should be, deploying. 2 is, will this create or utilize infrastructure that we'll be using tomorrow? And that's the alignment perspective. So if we want to create this kind of fused understanding of our overarching environment, right? Well, then, yeah, like a standalone unintegrated timer for the chicken nuggets that doesn't interact or interface with any of the other technology is probably a suboptimal investment. You really want to make some bets and say, here's kind of what we're investing in. And make sure that the new technologies that you deploy are kind of aligned with the infrastructure that you're either using now or going to be transitioning to. And that means saying no to a lot of cool stuff because there's just too much innovation, too many shiny things and new capabilities out there. And it's just impossible to have all of them be fully aligned. And you have to kind of make some bets. And then third is my net outlay small or negative? And so that's kind of the return on investment issue. And that comes back to kind of a practical financial reality, which is that we can't spend any more money. We just can't, okay? Our margins are razor thin. We've pushed kind of pricing as high as it'll go, already consuming, X% of the, GDP. And so, if we spend $100,000 on a new piece of technology, it's really got to replace $100,000 worth of spending somewhere else. Does it have to be perfect? Like, do we still do things because they're just right for patient care? Absolutely. But generally speaking, for these big infrastructure investments, we can get away with spending an extra $50,000 or $100,000. But when you start to talk about spending $5, $10, $15, $20 million, there has to be a correlated decrease in spending elsewhere. Meaning you have to automate away some amount of labor. You have to improve productivity in some kind of way. Otherwise it's just not tenable.
What's the timeline for that ROI? Because in a way, a lot of what you can think of it as capital investment that will generate a revenue stream down the line. And here at Hopkins,
it varies. Honestly, the best answer I can give you is probably about a year. We do, just to give you a really practical answer, we typically price things out over 5 years. So that's
Yeah,
probably the
that's-
longest that you can get away with. Right? If your technology kind of generates a return in year 8, it's a really tough sell in today's operating environment.
Yeah,
Yeah,
Do you think that's particular to here, or do you think that's generalized?
no, I think that's everywhere.
Do you think we're worse than?
No.
Just based on the state and the way billing and stuff?
Maybe difference in degree, not in kind. I think these pressures are everywhere. There are very few health systems that I'm aware of. Let me know where they exist, because I'll, like.
well,
But that just say, oh, we've got so much excess capital and we're just, our margins are so high that we're gonna just, invest tons and tons of money in stuff that might not work, and if it does, we're only gonna see a return a decade or.
no, well, there is an opportunity for philanthropy here.
Yes, I think that's right.
But I think the challenge we have certainly in Hopkins is if we don't make significant investments, we'll never get there. And there's a challenge of how you do that.
Yeah. I think that's right. And I think that there is there's also kind of an evolving understanding. I mean, I say this as like a very practical kind of like current state guide. But we are, a lot of it is sort of like an expansion of consciousness, if you will. I hope that doesn't sound too kind of, ooh, but we're fine spending $200 million in capital on new physical plants, opening up a new kind of ambulatory center, et cetera, et cetera. And I think that's because there's a level of comfort with and a level of kind of perceived certainty over kind of that return. With technology, like we're very, very bad at predicting. And you look at venture funds that are kind of held, they perform poorly. They just do. Like they're not great venture funds, and so I think that I think that there's room to move the needle on this kind of stuff. Maybe as we get more comfortable with sort of making these big infrastructural investments in technology and kind of getting a little bit more time under our belt to be able to predict those returns.
Yeah. So I just want to interrupt for a second. I think we got about 5 minutes left, and we have probably close to, well, I guess we have about 25 people online. So I just want to make sure folks online, I think we're into the discussion phase of this. If you want to raise your hand or whatever and jump in, please
Was
do.
there any other particular thing that
This is pretty much my last slide. I was going to give a couple of examples of what we're doing. I mean, in 10 seconds, one is scale. We're deploying LLMs to do more clinical data abstraction, to be able to get more alphanumeric data with clinical outcomes that matter. Like, did this patient have a surgical site infection? What kind of hernia did this patient have? What kind of molecular sort of genetics, did this tumor, entail? And then the scope is clinical sensorization. So we're deploying cameras in a lot of clinical settings, microphones in a lot of clinical settings, other sensors, experimenting with things like millimeter wave, for respiratory detection, et cetera, et cetera. And so doing kind of that data scope work, and just some operational examples of the stuff that we're doing kind of today, right now, to expand the scale and scope of our data collection, aggregation, and kind of predictive work. That's it. That's kind of that's everything that I had to share.
I have one final question. Can I get you to give a talk for my computer integrated surgery class? I'll talk to you on the way out, but I want my students to hear that talk.
Sure. Yeah. That's great. Thank you, Peter. That was terrific. So, yeah. Anyone online have any questions here? I think.
I don't see anybody up there.
Yep.
No. Peter, in your underlying conditions of healthcare at the beginning of the talk, one thing I don't think you addressed explicitly, maybe implied, is access to healthcare and unevenness of healthcare. That unevenness of healthcare in the US is particularly concerning to me. If you drive even an hour west of here, it's a completely different world of healthcare. The joke is, if